woman in their third trimester,
Mhm.
and you want to call med control, and med control says, yeah, go ahead and do it. I mean, you then also have the responsibility to tell the patient, hey, this medication has been known, da. Like, do they have?
You do not have the
opportunity
responsibility to do that, in my opinion. I don't think you have a legal responsibility to do that. But I might. You know, I might say, hey mama, look, I got a med for this, but it's what we would describe, I need a doctor to approve its use in your situation. Now, ideally, I guess, that patient would just listen to doctors. If a doctor says it's good, I should do it, right? As a patient, I'd want to know that. I'd be like, nah, dude, I can bear it. It's not worth the risk. So I would say, I'm pretty sure you're not legally obligated to say, hey, this is technically a contraindication, but I got approval from a doctor. I don't think you're obligated in any way to say that. But you are obligated to do that because you are ultimately working as an extension of the doctor. Now, I don't know what his responsibility would be disclosing that. Honestly, probably not. I think if you went a step further, like category X and the like, I think this, I'm trying to remember, I want to say that this used to be rated category C, so you can go to D and you can go to X. My guess is that at some point you have to say like maybe the D is like I have to advise them, and then X is I don't care if you asked, it's a no. You know what I'm saying? So, but to answer your question, I don't think you have any legal obligation to tell them that specifically, but you know, I might. I might say, hey, look, I'm not going to give you this because you're 28 weeks along, but I'd be happy to call a doctor if it's something that you felt would help. And if they're like, I mean, I don't know, ask the doctor. Great. I personally don't like to involve the patient in those kind of decisions, especially during their distress. I'd rather the doctor make that decision for them. So, say, hey doc, I got a woman, she's 30 weeks pregnant, severe pain so bad that she can't sit still. I'm worried she's gonna fall off the stretcher. You see what I'm saying? I mean, I'm not just giving this, I'm saying, well, it kind of hurts, then I'm not even gonna offer it. Like, if I think that it's, because that's all category stuff, right? Like, do the benefits outweigh the risk? You know, in pregnancy, so I've heard, it can be painful in labor specifically. I don't know that ketorolac will even touch some of that pain in the first place, but. All right, NSAID analgesic. So naturally we put here allergy. That means allergies to ketorolac or NSAIDs in general. Guy says, I can't take ibuprofen, my doctor said I'm allergic to it. Well, if he doesn't know whether he's allergic to NSAIDs in general, I'm still probably not giving him this because they're all in the same family with NSAIDs, right? Same as aspirin, not the same as Tylenol. All right. We in our groups, Trinity always alone. Let's answer these questions. Who should I be giving this to? Who shouldn't I be giving this to? What's the dose? IV dose for a 70-year-old. What's the IM dose for an 8-year-old? Can someone verify? Did I write IM on the?
It's IV for 15.
On the drug card, it's okay? Okay, great.
Oh, and I figured out the actual milligrams per.
Milliliters per kilogram? 0.47. It's not as sexy as 0.5, but technically, yeah, if you want to throw into your calendar, that was a weird thing. It'll be less helpful in a calendar. You want to throw into your calculator, my patient weighs 10 kilograms, so times 0.47, right? So essentially then we would just move it over 1 and it's 4.7 or milliliters. We were close, 0.5 is close. And honestly, I gotta be honest, you'll get it wrong on the registry or on a test if you say 0.5, but I'm telling you, it's close enough. Dude.
Like in real life.
I mean, if you, for the rest of your career, just said, I always give 160 to pediatrics, I don't care what their weight is. I'm like, yeah, you'll be fine. However, let's reference Colorado again. We said that about ketamine there too. And if a cop pushes a guy down and chokes him until he dies and you gave double the dose of Tylenol you should, it's possible they blame you for it because you gave too much.
Whole Colorado thinks.
Thank you, 0.47, that makes sense.
Also, can we go through your formula
For what?
at some point we'll do it together now, but like the way I found to do the math for it makes more sense in my head than the way you do it. So,
Meaning desired over have?
yeah.
Okay,
But I'm
sure.
gonna-
Yeah, how about we do this? Since I'll be, sure, I'll be interested to hear it. Maybe before you leave we can talk about it, and then Tuesday it might, maybe I can present both if I find it valuable.
So it would be 25.5.
The desired over have formula revolutionized things for me because I was looking at every med with its own formula, and my wife was essentially like, "This is just algebra. You can interchange these things. It's a simple formula." So I went into looking and found the desired over
7
have.
is 25.
I think it might just because I don't know like
7 is
the
25.
words yet.
Yeah.
So it'd
So once
be
it goes
27.
Well, see, incidentally, I only even teach desired over have because that's what most of the EMS community says. I personally prefer desired over solids times quantities because that's how my brain works. Like, how much milligrams do I have in this milliliter of solids and liquids? Whatever gets you there, I don't care what you use. There won't be a test that says, what does the D stand for? What does that H stand for? It will be, what is the dose? And however you get there, it's up to you.
It's janky. I only know the 0.5 because I forgot the 0.5 on the 17.
Is anybody done?
Work in progress.
Okay.
Yeah. Yeah. So 27.5 times 0.5. And that is for, that's a milligram.
And there's 30 milligrams. So what divide that by 30?
Yeah.
It'd be 0.5.
And milliliters, and I think it's like billion.
Do me a favor.
So it's still 0.5.
This
Well,
is
Point
1
Okay.
to
46
1
maybe?
total. 1 milligram to 1
Well,
milliliter. Or let's even easier. It's not easier, but what's more appropriate?
so for repeats, for IM and IV is the same repeats. So that would be both for IV or IM dose for
No, that's
each.
true.
For calorics, I'm talking about, so with numbers like this, do you round it? Or do you want the,
I'd probably say like around it.
I want to get some experience in drawing some.
Maybe.
do you round for my mom?
And like,
So you can round in real life in some cases, and you can never round on a test.
okay, cool.
So I will say that, like, for example, especially in something like Tylenol, 160, 162, who cares, right? Because it's 2 out of 160. But on the test, it might say something like 160, 159, 158. So rounding might get you in trouble there.
So like for this, like if this was on a test, you would round it to like 0.46.
You would probably, I don't have any essay stuff, so you would be looking for the answer that is closest, and that's how registry will work as well. Registry will say 0.46, 0.458, 0.49, and so you would want to pick the answer that's closest.
That's what I wanted to learn. That math is fun.
I think the more I do it,
Yeah,
just do it.
You guys got anything?
definitely.
How much would I give an IV dose for a 7-year-old? 15 what? Bananas? Milligrams, right? Now we'll get into later about how many milliliters that equates to. It depends on your concentration and the like. How much? What is the IM dose for an 8-year-old? Let's say maybe Courtney's group,
Yeah.
right? So we know our dose here. IM IV is the same, and it's 0.5 milligrams per kilogram. So what do we figure an 8-year-old weighs? 1, 3, hands up, right?
27.
1, 3, 5, 7, 9, so it's somewhere right here, 10, 15, 20, 25, 27.5. Well, our dose is 0.5, so that's half of that, right? Right? 13.7 or, is that right? 13.7?
13.7.
Why is that? Maybe 24. Yeah, okay, yeah, 13.7, sure. So we're looking for around 13.5 milligrams. Now, we could get into later how many milliliters that is. That's gonna happen Tuesday, and that would be the desired over have, or whatever the case is. Did that make sense, or is that a confused face?
A little bit.
Okay, so let's go like this, right? Let's do the easiest one. How much does an average 1-year-old weigh? 10 kilograms, right? We start with age 1, we start at 10 kilograms. Okay, well, if I need 0.5 milligrams for every kilogram, that's 0.5 times 10. What's half of 10?
5.
So your patient at 1 year old can get IV IM ketorolac 5 milligrams. So essentially, this is like saying, hey, whatever their weight is, cut it in half for milligrams. Now, as far as what that equates to in milliliters, this is 30 milligrams in 1 milliliter. What did we end up saying? 17? 13.7. That's pretty close to, it's going to be around half a milliliter. Because if it's 30 in 1 milliliter, and I need 13.5 or whatever the case is, it's gonna be about half in milliliters. Again, Tuesday's the day we're working on milliliters. Right now I just need milligrams from you. So let's try it again, right? Let's say that you have a 3-year-old. What's the average 3-year-old weigh? 15 kilograms. Now, what's our dose for an IM ketorolac for a ped? 0.5. So how do there are 15 kilograms times,
0.5.
which is, what's half of 15?
7.5.
There you go. So how much do you give? 7.5 milligrams. And then the question will suddenly become, great, 7.5, how much do I draw up? And that's what we'll do Tuesday. But the milligrams is what we're doing now. Look, worst case, you kill somebody, okay?
It's fine.
Yeah, I don't see what the word
Eat
is.
them kids, it's fine.
What ultimately, we use these terms like medication and drug, they're interchangeable language, drug, medication, but what makes them good and bad? Or let me ask you, are there bad drugs?
Yeah.
Yeah, I'd argue that there are some bad drugs.
Benefits outweigh the risk.
That's where we're at.
Depends, yeah.
And what we're talking about there, do we know what we're talking about? Like, let's say,
Every med has a
everything,
consequence. Has
right?
a,
You can eat so
Depends
much
on the dosage and
pine wood until it's a problem. You can eat handfuls of grass to a certain extent. You know, aspirin is okay until it kills you. I mean, you see what I'm saying? You know, you can drink a tiny amount of bleach. There's your homework, right? You can prove it. No, do not drink bleach. Do not drink bleach. Okay. The point is all things in moderation. The point is that everything is a poison at a certain dose. Right? And what we're really discussing here is what we call the therapeutic range or the therapeutic index. Like, what's your dose for an adult who's 70 years old, who's experiencing pain? You've decided you want to give Toradol to them. Let's say you want to do it IM.
13. Wait, hold up.
But it's half
No, but it's
dose
half
for-
Because he's 70.
Yeah.
Good job, right? Good job. Okay, so we say 15 milligrams IM. The reason it's 15 is because we found, now I'm just gonna make some stuff up, but we found that at 10 it does nothing, and at 30 it hurts them. So our dose is 15 for people over 65. And that's the therapeutic range. Too much, it's a problem. Too little, it does nothing, or in some cases, causes a problem if you just give a little. So this goes back to a conversation that we were discussing regarding pharmacokinetics. This talks about your absorption, your distribution, your metabolism, excretion. Admittedly, I don't think you're going to see a ton of this stuff on the registry, but if any of this is confusing to you, what toxicity is and the like, or what the word pharmacokinetics mean, I recommend that you definitely look that up. With dependence comes withdrawal, like everything, right? What's something we learned about that we didn't really have a major way of affecting it, that we learned about as far as dependence and withdrawal status? Maybe that was weirdly worded.
What are you looking for?
What is a condition that we discussed at length that you encounter when you're going through withdrawal?
Delirium tremens?
That's where I'm trying to go, right? Because, much like if I'm pushing, I guess it would be, right, if alcohol is a depressant and it's constantly pushing you down, your body to live has to fight against it. I take the depressant away, you suddenly go into delirium tremens. You're tacky, you're breathing fast, your body is now so used to getting pushed down that it can push up really hard. And so dependence and withdrawal is the occurrence there. You become dependent on it, which means when you don't have it, your body fights in the wrong direction against it. And it can happen for everything. You know, stop drinking coffee for a week, reduce your sugar intake, watch your calories, like all of these things your body becomes dependent on, good or bad. And the therapeutic range or index of those things, we say, well, I mean, you can have some sugar, too much could kill you though, right? You can have some cocaine, too much will definitely kill you. And admittedly, I would put cocaine in the group of things that are just essentially always bad. You know, meth, heroin, and cocaine is what I would say all fall into a category of things that you should never try once. I have plenty of friends that did and were okay, but I do not recommend that at all.
Yeah, don't want to tempt fate with that one.
Say it again.
Don't want to tempt fate with that one.
I've had people that tried each one of those drugs once and never came back.
Mm-hmm.
I've had friends that are still taking Molly and live mostly fine lives. I don't know how they do it, but they can. But those 3 drugs are ones I'm like, I've met people who did it once and never came back. No way. So we talked about this in passing here a little bit, just about how the differences between pediatrics and geriatrics, about how we start having the dose, halving the dose essentially of Toradol and the like, and how these things can affect babies differently. You'll see this here once we start talking about IV epinephrine, how we, with pediatrics, we start doing weight-based, and when they become neonates, we double the dose. They actually need more epi than the pediatrics, so it's almost like a curve that comes back up. And you say, well, that's odd. I thought the smaller we get. Well, it's different developmental stages and different sizes and capabilities of organs and reception to sympathetics and stuff like that. But more than anything, this is my reminder that if I hadn't talked about the differences between this is why we have weight-based dosing. This is why we have different dosing categories for adults and geriatrics, and why we have different dosing for pediatrics and neonates, is they all have organs in different stages of development or entropy, the regression. Nitrous oxide. Do you mean to pause for any reason? Are you okay?
Yeah, battery died. I have another one, but
It's because I'm so just wearing that thing out. Also, I turned it on when you were gone, so that way it would drain. No, we can take a break if it would be beneficial for you at all, Tina. No? Good. Nitrous oxide. Nitrous oxide is anybody? Well, I don't know. I should ask. There is such a thing as what's called whippets. Taking nitrous oxide, it's a weird thing. Do you guys? I don't know if it was like an age thing. Some people my age, huffing. You guys remember huffing? People don't do that really anymore, right?
You'd be surprised the amount of markers.
I was surprised then, coming off the bus and watching my buddies puff, and I'm like, I knew nothing about science, but I'm like, you are feeling strange because your brain is dying. What the hell? What the hell, right? This is a little different. And we're not entirely sure why. First and foremost, nitrous oxide, or N2O, is not all nitrous. It's a 50-50 mixture. And so, I don't super know how this one works. Usually I see them where they have it feeds in a dual, and maybe that's what this is right here, but it's pumping in oxygen and nitrous. Mm-hmm. You see it a lot in dentists, obviously. So you see, here's your tank of nitrous, here's your tank of oxygen and the like. It's so funny, when I was in the field and I was teaching people as like a tutor and a mentor, this drug card was completely empty, and all it said was, this drug is dumb. Make sure that the patient holds a mask. That's all it said. Now, since I'm like a professional adult and stuff now, it doesn't say that, but it could. You see, nitrous oxide is what we call a gaseous analgesic. It is a pain reducer, right? It does have some partial opioid receptor effects. It does, but it is not an opioid, and it is therefore not affected by Narcan. But it does have some effects on the opioid receptors. This is as simple as, you could see a registry question that said, your patient is complaining of left arm pain, what should you do? Nothing, something, nitro or nitrous oxide, and that would be the answer, because it's an analgesic for pain. Both for adults and pediatrics, you just strap it to their face, that's it. Or let them hold it, which is my recommendation. Because what's happening is you are breathing in non-oxygen, it is displacing oxygen. If I choke you, you will get a little goofy because your brain will lose power. Also, in addition to 50% oxygen making you a little goofy, the nitrous has opioid-like effects, and it is largely harmless. Like, nobody's out there dying of nitrous, not that I've ever heard. Even whippets, when you're doing it at home and stuff, or whatever, never been my bag. But, those people aren't getting hurt, because what's the solution? What's the antidote? Just breathe. You'll breathe out the nitrous. It's not a big deal. This only really becomes a problem if it's strapped to their face and they can't breathe full oxygen. You will continuously displace oxygen on them, which is why I say, let them hold it. If it's too much, they'll pass out and they'll drop it, and then they'll fix themselves. Simple as that.
And then do it again.
All right. I don't want you to answer the first or second question necessarily, but I do want you to answer these questions down here. There's 2 questions here. Answer those with your partner.
Right now, you obviously take it off and then back warm so they are breathing, normal amount.
I can't tell the difference.
Is it my 1960s perfect feminine pear-shaped body? Nadia, what do you think? Your patient becomes bradypneic while you, what was that, Lucy? Oh, I saw it sound backwards. What that was? Yep. Okay. Bradypneic while you're administering N2O, what should you do?
Probably stop.
I like it. Good answer, right? What would you expect once you stopped? Okay, they're bradypneic, their respirations are something like, let's say, 10 times a minute, so you pull it off. Now what do you do?
Well, if they, I feel like bagging.
Yeah, I mean,
Start
bagging
giving
isn't
them
the
oxygen
wrong
or
answer, but here's my guess, is you pull that bag out, and by the time you got it on their face, they'd be fine. So, so really we come into that more when we get to the second question here. Tina, what should you do if your patient becomes apneic while you've got this mask on them? Take it off, and BVM is probably, if they've gotten to the point where you were like busy writing your report and missed the fact that they went apneic, it might be much harder for them to restart their own respiratory drive. You might have to bag them in that case. But both the situations start with you getting the mask off. If that's your guy's overdosed on heroin, he's still pushing it into his arm when you get there. Please sir, stop doing the heroin. Yeah.
Yeah, let me just.
So, do you know how long the pain portion of nitrous works? Right?
It works until you stop using it. It is instant. Like when,
so
admittedly, I only know it from recreation. And when you blast nitrous, essentially, you're like, whoa, I'm normal now.
so it's not something that like the portion receptor. So it's there and then it's not. And
That's right.
I'm back in it.
That's right. Yeah, it's just like DMT, if you've ever done DMT, where it's just like, I was never into those kind of drugs because it's like, dude, it's like the craziest 15 seconds of your life. I'm like, I have stuff to do today. That makes no, like, if I'm gonna drink a beer, I want it to last a while. What are you talking about? So, essentially, pull the mask off, it's gone.
So what if you do have a mask on? Can you not just put a nasal cannula under it so that way you're pushing pure oxygen in?
You are essentially saying what they would do. If you were a dental assistant, what you would be doing is, you wouldn't do a nasal cannula, you would just simply change it to more of like a 70-30 ratio, which is exactly what you're talking about. And in fact, that's how they tailor it. We just lace it at 50-50, but a dental assistant is just kind of there, or I don't know what their term is, but what their job title is. But that's what they would do, is they would just be like, oops, we need a little more oxygen, a little less nitrous, and much like what you would be doing there. So I would say, if you have access to nitrous, you won't need a cannula because you'll have access to the machine, which is titrating the concentration. But
So that's what they do during surgeries.
that is what they do. And then naturally, when they pull it off, you come back.
I was messed up whenever I came back from my wisdom tooth surgery, and I and I had nitrous oxide.
Oh, let's take a break, I guess. I don't want to do much. Let's do it like 3 minutes. You got to pee. Let it roll.
I was so.
Hey, where you goes to the bathroom, my son?
I was so messed up.
Have you ever seen that movie? Anybody? The Little Shop of Horrors.
Yes,
No.
there's a
The,
play
the
about
play
it.
with the nitrous oxide.
Yeah,
the dentist does
dentist.
it all the
Yeah.
time.
Dude,
Just like, I'm
I've
just
only
fucking-
done nitrous
Yeah.
once, and it was.
I
Everybody
was-
was doing
That's a
it with
classic.
was like having the time of their life.
Surgery, like
It was
I woke
the
up and I
most
almost like face
horrible
planted
experience
in.
of my
I
entire
almost tripped on a
life. It felt
smoothie. It
like
was great.
somebody just squeezing their fingers into my brain. I could not.
I
Nitrous.
I did everything with nitrous because I have really bad anxiety.
Yeah.
I wasn't supposed to, they didn't believe me, so they started.
Yes, I've had that happen.
Yeah, and I taped it and I.
Oh my God. How are you? It's cute.
What?
Wow.
Horse?
That's a classic.
Yeah,
It
this
is.
you.
Because I remember, like, I hadn't heard of it until, like, we did a play of it in high school, and then I was like, I have to see it now before, like, we even do the play. And I was like, I love it. It was hilarious.
Oh, overlap.
Yes, finally.
My spinal cord is half fused.
I'm so sad.
I want to pop it so bad. I just want to rip my spinal cord out like a Beyblade sometimes.
Just slice it a little bit. Just like slowly like
Drill out some extra bits in there, and that way you get a little bit of it leave, just a little bit.
intraosseous. The drill just.
Fuck off.
I wouldn't do it. I wouldn't